talk about today is how to think through addressing the mental health nutritional needs of a complex client. You know, where they have a lot going on, or where it just, you know, you've tried a few things and it's just not working easily. So this is the step-by-step process that you want to go through and that you want to think through. Okay. So we look at diet, we look at digestion, we look at absorption, we look at allergies and intolerances, and then we assess and promote neurotransmitter adequacies. We assess and rule out different issues, and then when needed, we refer. So let's look at step one. So the very first thing we want to be looking at is the person's diet adequate? Are there enough proteins, fats, and other nutrients in place? And we need to take into account, you know, a number of things: their ethnicity, their blood type, whatever we need to be looking at for them, we look at them for them. We may need to do nutrient tests to find out what the nutrient levels actually are. But so we look at adequate diet. And this is also where we do our 1 to 3 day food diary, or, you know, whatever kind of assessment tool you want to use to assess for the adequacy of the diet. Then you want to check to see if they are eating to support balanced blood sugar, and you adjust as needed. So the very first step is often really to work on somebody's diet and nutrient is there enough there? Is it adequate? Nutrient adequacy and blood sugar. Okay. Secondly, we then look at digestion, because as you all know, eating enough doesn't necessarily mean that it is going to be digested or absorbed. So then we assess for adequate digestion. So, and this is where we use the NAQ as well as other assessment tools, if you like them. Is there enough hydrochloric acid? Is bile sufficient? Are pancreatic enzymes sufficient? Is somebody on a proton pump inhibitor and needs to get off it? And then supplement or adjust as needed. And this can take some time. Then we want to look at adequate absorption and elimination. So this is where we look at the gut. Is there a healthy microbiome? Gut integrity. Do we have leaky gut? Are the bowel movements still having issues even though we've addressed digestion? We test and supplement as indicated. Now, hopefully by the time we get there, we've already addressed food intake. We've gotten rid of inflammatory foods. We've gotten rid of toxins in the diet. I should probably actually add that to the adequate diet list, that we're getting rid of, you know, the not useful foods, so that you're already on your way to healing the gut, but this is kind of addressing what's left. And then you want to check and see, are there any food allergies or intolerances going on? Test, eliminate, challenge, and possibly treat if treatment's needed, either using NET or some of the other methods for actually treating food allergies and sensitivities. This could include, you know, a histamine issue. Okay, so any questions or comments about this very first step? And for those of you who haven't yet taken level 1, level 2, point 2, 3, and 4 are taught in level 2. Okay. Step 2, assess and promote neurotransmitter adequacy. So this is where you assess using the amino acid therapy chart. You trial indicated amino acids. If there's an inadequate response, you raise doses or check cofactors. If you have adverse reactions, you go to plan B or C. And then you want to check for other underlying reasons that amino acids may not be working. Now, of course, you might be doing this parallel to step 1. Okay, that doesn't necessarily mean that you're not going to be doing any supplementation or amino acid therapy until you've completely finished step 1. No, we all know about using the supplements and the aminos to jumpstart the system and to fill in the gaps while you're doing the rest of the work. But in terms of thinking about it, this is sort of the next thinking step. Step 3, and this is the bulk of level 2, is assessing and ruling out or ruling in underlying nutritional or physiological or medical disorders. So pyroluria, if people are having a really negative reaction to say 5-HTP, or they're really looking like they may have pyroluria and they need cofactor support, use the questionnaire, test, and then treat. Looking at hormone issues, and again, this is where we use both the NAQ as well as other questionnaires. We want to look at thyroid, reproductive, and adrenal issues, and again, assess and support or refer out. We may want to look at, if there's enough sophistication, methylation and other genetic pathways. Could use here the GARS test, as well as, looking at the whole methylation pathway and other genes that impact mental health. You may want to be looking at detoxification pathways and issues. This is where you're going to be looking at liver health, as well as, aspects of methylation and detoxification. Because if there are blockages here, you're going to end up with difficulties in neurotransmitter production. For instance, if you have a whole bunch of toxicity going on or a high ammonia, you're going to be eating up your BH4, your tetrahydrobiopterin, which is a rate limiting factor for turning your aminos into neurotransmitters. So that may need to be addressed. And then if nothing's working, or if this is in your face, looking at chronic infections, biotoxins, heavy metals, the stuff that could have been there for years and years and years, that are kind of keeping everything and anything from working. Hi, Virginia, welcome. And so this may need to be assessed. Now, any individual practitioner may not have the skills to do this. Your job may be just to identify that these things may be going on. And then you do step 4, which is refer. So always refer if anything comes up that's outside your scope of practice or expertise, knowing that you absolutely do not have to do it all. So if this is the basic framework, let's go back to the beginning. And let's just have a conversation about what this looks like in practice. in both practice as a nutritionist or a doctor, as well as practice as a psychotherapist. So, oh, hi, Kathy, welcome. We got some more people here. So, who wants to start?
I'll just make a couple of comments that, when you begin with somebody, it can be very overwhelming. And the biggest thing is the diet. You can get lots of good response when you get them balancing that blood sugar. That can take them off of that roller coaster ride of up and down emotions that can make them feel like they have every mental health issue on the spectrum. And once we understand that, it's a lot easier for the client. And once they understand that, for them to understand the importance of their meal and making the connections throughout the day. Because so many people that I work with, they have no idea how they feel when they're hungry. They're not connected to their hunger. And this bringing it to their attention when we go around a room of a group of people and ask people to share, how do you feel? Some of them are like, I don't even know. And others share something. And then that person says, wow, that's why I look, oh, that's why I could be that way, because that happens to me. Now they've made the connection. But it's really a big education to help them understand just the basic 3 meals a day, 2 snacks if needed, and hydration.
Yeah. Yeah. So this by itself could be a couple of sessions.
Mm-hmm.
One of the thing that jumped out at me really is about the enough protein, and from the 7 weeks of sobriety, the different kinds of alcoholism. I thought that was incredibly informative. And I have a client who I think has the hypoglycemic alcoholic. And I always say to him, when you're on the road, which is when he tends to have a relapse, is if you're stressed, go find protein. Just find, it's like, if that's all you can do, just find some protein and make sure you're eating it every 2 to 3 hours. So I think that's a big piece. And I think, educating the client about the 7 different kinds is a nice way to piggyback on, are you eating enough protein and so forth.
Yeah, absolutely. And then do you need extra, GLA, for instance, gamma-linoleic acid. I just noticed that my bottle of borage oil is getting really low. And even though I just made a supplement order on Amazon, I think I forgot that. And I'm a little alarmed because it means I'm going to have to, do like a half-hour drive to the vitamin store, and hopefully they'll have either borage oil or evening primrose while I order it, because I'm one of these people where I literally cannot afford to go for more than 2 days without my borage oil, because I will get depressed. And then, while I don't have it up here, what I just mentioned is bearing in mind that part of the adequate diet, and certainly one of the steps in our 5-star pro recovery diet is clean food. So really making sure that people are beginning to eliminate the inflammatory food, the simple sugars, and the toxins, and just let them know why it matters. Not just, oh, this is bad food or this is bad for you, but this increases your toxic load, and toxins make you depressed and anxious and tired and yucky. We have to connect the dots for our clients.
I also, and it makes me always think of a many years long friend of mine who does this as far as digestion. I don't know if it's a particularly American thing or not, about chewing your damn food and not washing your food down with your liquid. It's like so prevalent. It's like chew, 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 drink. Like it's almost like they're swallowing their food almost whole. And like, I don't think any doctor ever mentions this to anyone. Anyway, just throwing that out there.
Chewing is important. I'm actually of a mixed mind with the recommendations that you don't have liquids with meals. And that's because if you look at most societies throughout history, liquid has been consumed with meals pretty consistently.
Yeah,
So where I have come to sort of, where I've come to in my thinking about this is you absolutely, and I mean, we drink soups, right? Which is, water added to your food. So my sense is that we don't want to rely just upon hydrochloric acid to moisten the food and saliva. Sometimes our food is really dry, and we do need to moisten it with water. It does have to be liquid enough in that stomach of ours for it to all mix. And I think depending just upon hydrochloric acid to moisten it may not be sufficient. On the other extreme, we don't want to drown our food either. We don't want to be drinking a whole liter of water with our meals, because that is liable to dilute the hydrochloric acid. But the belief that any liquid at all with meals is going to dilute your hydrochloric acid to the point that it's not doing its job, if we look throughout history, I just don't think that holds up.
no, I agree. I'm thinking of these extreme people who, like this one got like literally every bite of food. You barely choose it, and it's always cold drinks too. Big swig of cold drink. It's like, and the guy has so many issues.
Yeah.
And just doesn't want to hear it, Yeah.
Right. So that's definitely what you need to be paying attention to, and always encouraging people to chew, to be mindful, to slow down, because of course we know that when we're in sympathetic arousal, that significantly impacts digestion by reducing the amount of enzymes that are produced and reducing motility and peristalsis from the top to the bottom. So noticing these things, having this conversation with our client is one of the very first things that we need to be doing. And for therapists to get comfortable asking your clients about your bowel movements. Yes, indeed.
Christina,
Yes.
I just have a question about the digestive part. How do you know the difference of when they would need hydrochloric acid versus bile versus pancreatic enzymes? I know you've talked about it before about.
So Valsa, that's where we use the NAQ, the nutritional assessment questionnaire, or which is referred to in this particular book, Signs and Symptoms from a Functional Perspective with Dr. Weatherby, because it separates out those symptoms very easily and clearly. But low hydrochloric acid tends to be digestive problems at the time of the meal or shortly thereafter, including heartburn, gas and bloating, belching, or getting full very quickly, or diarrhea right after the meal. Those are all signs of low hydrochloric acid, and especially heartburn and GERD is the biggest one. Lack of bile, which, bile emulsifies our fats, and therefore is necessary for fat digestion and proper absorption. So one of the things we all have to be remembering to ask our clients, because they don't always tell us and we don't always ask them, is if they still have a gallbladder. Because this matters. Because most people without a gallbladder are not on sufficient replacement enzymes. And so their fat is just not getting sufficiently emulsified and therefore digested. You can have pain between your shoulder blades. You can have pale stools that float. You can have, it looks like there's a little bit of oil floating if you're really not digesting your fats at all. you're going to have a little bit of oil floating on the top of the water in your toilet after you have a bowel movement. So these are, there are other symptoms as well. These are signs of lack of bile. And then lack of pancreatic enzymes. We pretty much know that if somebody doesn't have enough hydrochloric acid, or if they're on a proton pump inhibitor or other acid reducers, that they're not going to be producing either enough bile, nor are they going to be producing enough pancreatic enzymes, because the food, when it moves from the stomach into the duodenum, has to be sufficiently acidic for sufficient release of bile and pancreatic enzymes. So you already know that going in. But other signs are, of course, diarrhea, constipation, gas and bloating a couple of hours past the meal. So if the symptoms are immediately, that tends to be a hydrochloric acid issue. If it's a couple of hours later, that tends to be a pancreatic enzyme issue or other issues with the small and large intestines, such as leaky gut, inflammation, food intolerances, whether it be casein or gluten, or dysbiosis. Does that answer it for you, Valsa?
Yeah, I was just curious, how you, and then, pancreatic enzymes also, right? Like I do some testing for the gut. And so sometimes I can get some information from the GI test.
But you can get a lot of information before the GI test, just from acute symptoms.
Yep.
And, if I have a client with irritable bowel syndrome, for instance, or some of these other inflammatory things, the very first thing I'm going to do is add pancreatic enzymes and see what happens.
Do you like a particular brand of enzymes? Do you just do?
This is one that I like. I mean, there's a number of them that are really good.
Oh,
But
now,
for people who, want to buy their things either from Amazon or over the counter, this is a nice one. It's called Super Enzymes by Now. It actually is a full spectrum enzyme formula. So it has 200 milligrams of hydrochloric acid per capsule. So that's actually useful. It has a nice amount of ox bile, and then it has good amounts of everything else.
I'll go get it. Thank you.
Yeah.
Bye.
Oh, bye, Virginia. So, you can get a lot more sort of sophisticated, but if you want to just kind of bring in something to see to cover all the bases, that is a really good, useful one.
Yep. All right, great. And that's the one you use in general, right? You don't use like bile if someone is having the 2 hour, like you mentioned, the 2 hour delayed, and you think they're having difficulty with emulsifying fats. Would you do something differently, or you think this is
If
adequate?
somebody does not have a gallbladder,
But they have a gallbladder.
okay, yeah, if they have a gallbladder, I'm going to start with something like this and see if it's sufficient. If it's not sufficient, then I'm going to ask if they have a gallbladder issue, right? Because, the body is supposed to be squirting enough bile in. So my question is going to be, why isn't it? Is it that the food called chyme from the stomach is not acidic enough? Is there a blockage in the gallbladder? Do we have a liver issue? So yes, I'm going to come in with solutions and symptom relief as quickly as I can. And at the same time, I'm going to be asking the question, why? What's keeping the body from doing effectively what it was designed to do?
Yep.
And so I always have this two-pronged approach. But yeah, I'm going to do symptom relief while I'm trying to figure out the deeper questions.
Thank you.
Okay. Any other questions, comments, stories about this page?
If you want, I can just give you a general comment, not necessarily about this page.
We always like general comments from you, Valsa.
So there's a new group that's been formed called Metabolic Mind,
Uh-huh.
and they have a series. I think it's maybe venture capital funding, and so they had a bunch of researchers and clinicians come together I think it was last spring, where they're really focusing on the ketogenic diet
Yes.
and mitochondria as a way of resolving some of these significant mental health diagnoses like schizophrenia, bipolar,
Yeah.
and I think we mentioned Chris Palmer. His book was The Brain Energy, where he's talking about mitochondria and ketogenic diet. So there are a lot of researchers just focusing on the ketogenic diet as a way of resolving, maybe
There are.
can even use the word curing, maybe, for things that we in the past would probably not think about as a cure, like schizophrenia and bipolar.
Yeah. Yep.
So there are a series of videos if anyone is interested in YouTube to listen to them. It's kind of short and
Oh, I mean, there's a lot of information out there now about using the ketogenic diet for major mental illness. I mean, that's the big thing right now among the nutritional psychiatrists. I have a little bit of a problem with it. In that I want it is a medical diet. Okay. And we have medical diets for liver disease. We have medical diets for diabetes. We have medical diets for kidney disease. Okay. We have medical diets for serious physical illness. So I consider the keto diet to be a medical diet for people with severe metabolic issues and severe mental illness. And it can be very, very effective because that's what the brain requires to heal itself. And maybe what the, glucose, metabolizing system requires to heal itself. However, that does not mean that one size fits all. That does not mean that the entire world needs to go keto. Because what's missing is people looking in general at their clients' and patients' diets. Most doctors and even psychiatrists are still not asking people, well, what did you actually eat today? Do you have a basic balance? Are you getting in the essential nutrients that your body and brain needs today through your diet? So I always think we need to do that first before considering the medical diet of keto. Are you actually getting the nutrients in that every brain needs fundamentally? And that's, I think, going to take care of a lot of symptoms, not all. Eating a really good 5-star pro recovery diet is not necessarily going to put your bipolar or your schizophrenia into remission unless it's due to gluten and casein intolerance, in which case you don't need to go keto, you need to get rid of the gluten and the casein in your diet. So let's again use a thinking process like this before we jump the gun and say, oh, well, he needs to go or she needs to go on a medical diet called keto. That makes sense to everybody? What are your thoughts about that, Valsa?
I thought it was very reductive the way they were doing it. They were just the entire, so as I said, Metabolic Mind.
Yeah.
They've formed this group. It was last year that they had this big conference. There's a lot of money there, and their only focus is ketogenic diet, which is a little odd. I think ketogenic diet has a place, but that's all they're focusing on. As you said, they're not focusing on nutrients and the gut microbiome, right?
Right. They're jumping the gun is what they're doing.
Yeah. And I think one of the things is that they get good success with it in a way. So they are sort of, or they're focusing on the successes they've had
Right.
and not on people who are not successful. And so, yeah, I thought it was just, it's interesting, you know, now we have integrative psychiatry, we have another group in somewhere else called, you know, we have Dr. Greenblatt's group, and now we have this other group called Metabolic Mind. But at least I think I'm happy that there is a shift away from medications, and that this shift is sort of saying there's something else besides medication that we need to look at to help our patients. Because I think, at least from the conventional hat that I've worn for many years, schizophrenia was always relegated very severe, something that we can't really deal with, something that's end stage, that, you know, once you have schizophrenia, that's it. But I think with the new thinking over the last decade or so, there's much more hope with patients with schizophrenia and bipolar.
Christina, I just really appreciate you saying that, because I've been saying that to people for a long time,
Mhm.
about the ketogenic diet being medical. And, you know, early on, it was a diet for epilepsy
Right.
before all the anticonvulsive drugs. And I have a family member on a ketogenic diet for epilepsy, and it is amazing what it does, but it's incredibly precise.
Mhm.
Everything is measured like in milligrams,
Yeah. Yeah. Yeah.
to make sure he's getting what he needs. So I'm just appreciating you saying that, because I don't hear anyone saying it. And keto has become such a kind of a bad thing that it just, I continue to have concerns about that, and I don't hear anyone speaking about it. So I'm just appreciative that
There
you're
is
saying
We
so.
need to hold things in balance. By the way, here is a list of many of the underlying drivers of schizophrenia
Yeah.
and things you need to be doing and looking for.
So my comment is, you take somebody and put them on a keto diet and they don't have enough sufficient hydrochloric acid and bile, they're going to be a mess. It's not going to work. They're not going to feel good. Nobody's addressed the underlying issues. What are the upstream issues that are causing all the problems? I have a very dear friend, keto worked excellent for her and her cancer. There is no one diet for everybody. And you can really put somebody in a difficult place if they don't feel good. And when you think about somebody struggling or dealing with mental health, they're usually not eating significant foods with nutrients in them anyways. They're eating a lot of inflammatory foods that are inflaming that brain, that's
Mhm.
keeping their mental health, you know, just that's those symptoms just spiked, right? So you calm down that brain inflammation by taking out those inflammatory foods, and then get them a little more stable, get them understanding why I'm eating what I'm eating, helping them to create foods that they like. It's not about eating food you don't like, it's about finding food you like. And then from there, you have to look at all of these things that you've just listed here, because if you do anything like that and don't address their digestion and their absorption, it's going to be worse. And they're going to say, this doesn't work. So there's so many different pieces of the puzzle, and there's so many that are being missed. And I find that most doctors never ask their client, their patient, what are you eating? And I tell my clients, if you ask your doctor, how much does this have to do with food, and they tell you nothing, then you just exit.
Find a different doctor.
Find a different doctor. Be very, hey, yeah, thanks so much. And get another one, because food has everything to do with it. And then how am I digesting it? How is it working for me? Even myself as a nutritionist, it can be very complicated to figure out what's best for me. And there is no one diet for everybody.
Mm-mm.
Depends on the person. Everything is true, but partial.
Mm. And again, here's an approach to bipolar.
Mhm. Yeah.
There's some books. Okay, let me go back. There's a lot in this lecture of mine. Okay. So anything else about this page? All right. And you know, this food allergies or intolerances Again, you know, we need to think about the small subset of people with alcohol use disorder who seem to not be able to stop drinking while they're still eating gluten. And so we want to be asking the bigger context questions. So I have this one client that was the case for him. And in my kind of assessment interview with him, I said, well, do you have other family members who have either health issues, mental health issues, or addictive issues? And he said, well, you know, so in terms of general health, I have a sister who got diagnosed with celiac disease. Okay. Right, flag. I said, oh, that's interesting. He said, yeah, she does much better off gluten. I said, huh. Well, you know, given that it's genetic, have you ever gone gluten-free? And he said, yes, I actually went gluten-free for about 2 years. So what did you think? He said, well, you know, I really liked it. I really felt, you know, much better going gluten-free. I said, and what happened to your drinking while you were gluten-free? He said, you know, funny about that. That was the only time in my life that I've actually stayed sober for an extended period of time. Bingo. Right there, told me everything I needed to know. And I said, and I explained to him the connection that I thought was true. I said, would you be willing to go gluten-free again and see if that reduces your cravings? And the next week he came back and reported he didn't have a craving all week. And he was able to stay sober the whole week with no problem if he stayed gluten-free. And then he went on a backpacking trip several months later, and he was leaving the food to his friends because, you know, he's not yet realizing he has to take care of himself around food. And they brought cookies and sandwiches. So he spent 3 days eating cookies and sandwiches. Felt like crap. Ended the backpacking trip. They're walking into one of these Colorado mountain towns and walking past the bar, and the bar is loudly calling his name. Loudly calling his name. Now, it wasn't calling his name when he walked past the bar at the beginning of the backpacking trip, before he'd been, you know, on sandwiches for 3 days, but it was certainly calling his name coming back into town. But he knew the connection, so he was able to tell himself, oh, this is just an allergic reaction. Just ignore it, ignore it, ignore it. You'll feel better tomorrow. Just get into your hotel room where you're safe. Don't turn into the bar. And he didn't. And he stayed sober, but he reported that to me and he said, it was so clear. So these things matter. Okay. Assessing.
Hi, Christina.
Yes.
Hi, it's Kathy. Glad to be here. I do have one other question. Can we go back to that first slide? So for balanced blood sugar, I do have a question. And it goes back to something that Balsa had said on one of our recovery food eating recovery meetings. Balsa, you had hopped on with in a conversation that we were having, Patty and another gal, Sandy, and we were talking about the glucose monitors, blood sugar, CGMs, and you had mentioned that trying to keep blood sugar under 100, and this was a question that I had even when I did a metabolic reset with another business coaching program. And so I stay a little confused with, is it okay for the blood sugar to rise and fall in the period after eating to, 140 back down to its normal level within a 2-hour period? Or is it best, even with eating, to keep it under 100? And I'm not necessarily also directing that question at you. It just piqued my curiosity because several of you know I'm wearing and have been for a while trying to decode my own blood sugar
Good for you.
balance issues. And, you know, it still perplexes me. I have realized that the more paleo I go, the more brain fog I have, which goes against a lot of things. But then I've been doing some reading with Dr. Amen that he says some people with, depending on their type of ADD, higher protein can be not really good for them. And so I sometimes just think I'm an anomaly, but I try to remember I'm just not that special. But so anyways, I just, you know, I throw that out there because my sugar does, when I eat like really good paleo, whole vegetables, even like lots of free, like more even waterier vegetables, my blood sugar still can be quite elevated. But I do feel better now bringing in some oatmeal, some gluten-free grains and legumes that are supportive to my blood type. So I am staying in those constraints. But you know, that blood sugar still goes up quite a bit.
So when you say
and some-
quite a bit, where
Well,
does
over
it go?
over 140, and at sometimes, you know, in upwards of like 160 or 170. And
You know what
I think
foods create that type of jump?
more towards the fruit. I mean, it is the starchier and fruit, and I'm talking even blueberries added in with a meal. Now, if I separate them out then and have them separately, then it's obviously, you know, it's a cumulative thing. And I try and check my nervous system. Like I try and, like, you know, take a deep breath. I watch my pacing. I try and keep it over a 20-minute period. But it's kind of two questions in one. So yes, it's going above the 140 even at times. So, and I know there still might be a liver issue in there. I haven't retested for my mold to see where my mold is at.
Kathy,
But
again, how long does it stay high?
oftentimes it is back down within the 2 hours.
Yeah.
But my other question was when Valsa had said, and maybe this is directed towards you, Valsa, with your clients and managing their blood sugar, do you like to try to keep them under, because I know you do work with a lot of keto as well, but do you keep them under the 100 even postprandial?
So different things. So a lot of people are using CGMs for longevity issues, and those folks are really trying to keep their blood sugar below 100, actually close to 80 or so. So that has to do with longevity and trying to, that's that group of people. In terms of the sugar for, say, a diabetic or a pre-diabetic, I think some of the numbers that I've heard and that we would like perhaps is at the 1 hour mark to have the highest sugar at 140. Because what we're at is insulin. It's not the sugar, they're both problematic. Both a high sugar and high insulin levels are problematic. So you don't want either of them to be too high. And with the CGMs, we're only measuring blood sugars over the course of the day. So with the traditional way of checking sugars, what I would have patients do is check their blood sugar an hour after a meal and see where it's at. And if it's over 140, I would ask them to adjust their meals to get that below 140. Then we would also do a 2-hour check to see where it's at. But there's a lot of data to say it's the 1 hour mark that we want to try to focus on to get the blood sugars to a certain level. So why are we interested in blood sugars? When you look at that, it's actually to prevent long-term damage from insulin and sugars to, you know, the blood vessels, to the cells, to the eyes, to the different organs. So one way to try to bring your sugar down is with your meals is to have the sugary part of your meal at the end. like the dessert or whatever it should be, or even your carbs. You can stack it like fats first, and then maybe protein, and then the carby part of the meal at the end. And another thing that some people suggest is after you eat, go ahead and walk for about 15 minutes, because that will allow the sugar to go into your muscles. So it doesn't stay in your blood. It sort of gets circulated out of the circulatory system and to the other organs, and preferentially goes to the muscles. So that will also be protective and gets your blood sugar down. So
Right. Yeah.
And then just one more thing, if anyone wants to know, one of the better sugars, if you are trying to look at a good sugar substitute, there's a sugar called trehalose, TREHALOSE. That is actually, I'm just starting to learn about it. It's supposed to be a better sugar. It's actually a positive cell signaling molecule. So it's actually beneficial if anyone wants to look at it. But
Okay, cool. So
Can
those
you
people
put that
that,
in the chat, Valsa, the name of that sugar, please?
trehalose,
Uh-huh.
TREHALOSE.
TREHOLS.
Trehalose. And
Okay.
yeah, maybe we can talk about it at one of the round tables or something. Someone has said, like, I've just started to investigate that molecule, and it seems to be like a sugar substitute, but really with positive influences for your cells.
Where
Rather
does it come from, Volsa?
It comes from plants. I think it comes from plants, and it's, as I said, I'm just starting to learn about it. And it's supposed to be like very much like the glucose that we have, but it signals the cells to function better. So rather than just being a sugar substitute, it's also positive in that it gives your cell some positive signals so that it functions better, if that makes sense. So it's not just about the sweetness. That's what I meant to say. It's not just about the sweetness. It's also about some of the other beneficial effects of that particular kind, that sugar. So Kathy, did you have a question?
yeah, I just wanted to make sure I understood you. So the ones that you were, they wanted to stay in the under 100 and closer to the, in between the 80 and 90. Those are for the people that are on keto. Is that correct? Is that what you had said?
More like longevity, people who are really interested, like they are like focused. It's the Pita group. There's a whole group of people who really think that if you get your blood sugars really low, like the lowest that they can be, they could be keto, or they use the CGMs to see what foods they can eat to keep that. So if you don't have diabetes, if you don't have insulin dysregulation, then it's, in quotes, easy to keep your sugar around 80, because that's supposed to be the normal, because that's if you're, if your body's working well. So for people
Even when you eat?
See, I'm just a little concerned. Again,
I mean, I would have to be eating a nut. Like, I would have to be eating a small handful of nuts all day long to keep my blood sugar under like 100.
It's only very recently that there has been concern about, not wanting blood sugar to rise at all after you eat, because they're, for a very long time, it has been considered normal for blood sugar to rise to about 140 within an hour, but not to stay there, and to start coming down and not to go higher. I'm concerned by anything radical. I am such a middle of the road person that anything that you want to be, you're having to focus so hard on changing what you do and how you eat and everything to try to keep something within a range that is set by ideology
And very rigid.
rather than, I think, enough science. So I'm just going to throw a word of caution in there. For a very long time, this gray line in the middle has been considered relatively normal. Okay, this person is not spending, I think this line starts at like 90. They're not spending a lot of time over that line, but you see it's moving slowly, it's moving gradually. We don't have great big spikes of insulin the way we do with this green line. The insulin's working, unlike with the red line, which is diabetes, where it's not working at all. So I really think we each need to be paying attention to how we feel, as well as our health markers, not just blood sugar markers, but what is our cholesterol? What is our energy? Do we have brain fog? What's our inflammatory level? We need to be looking at the whole picture. And I'm one of these people as well, Kathy, that I do better when I have some complex carbs in my diet. If I go completely paleo or completely, very low carb, I just don't function well at all. And way back, way back when, I did the Atkins diet as a teenager for maybe an entire year. And I was so depressed at the end of that year that I was almost suicidal, and I had to give it up because I just was too depressed.
A lot of this has to do with our metabolism and our metabolic type as well, not to be confusing all these things, but some of us do better on fats and proteins and not as many complex carbs, and others need more complex carbs and not as many fats and proteins. And the way they figure that out is doing this intense glucose tolerance test. And, when you look at your blood sugar being measured, that red line is showing somebody with insulin resistance, right? The gray line, somebody's eating a nicely balanced meal, so their blood sugar is definitely going to go up after you eat, but it isn't going to stay really high, and then it's going to gradually come down, and then you're going to know it's time to eat again, right?
Yeah, but let's remember, looking at this test, that, Francis, what these people ate at the beginning of this test was not nicely balanced meal.
No.
Okay, this was pure sugar at the beginning of this
Yeah.
test. And yet the people with, quote, normal metabolism, drinking 8 ounces or whatever it was of glucose syrup, their blood sugar did not rise very high.
So would that say that their pancreas is working sufficiently and they have good insulin receptivity?
Yeah. And so I'd be interested in looking at that line on a moderately, how do those people handle their blood sugar on a normal, moderately low carb meal. My guess is that if it goes up to 140 after 8 ounces of pure sugar within an hour, it's not going to rise that high, after a normal meal.
I think another marker that doesn't get done a lot is a fasting insulin to see where people are. And then doing that postprandial to see where people are and how much does it come down. And then also, that has to do with the compilation of the meal, right? Yeah. Keto is going to be more fat and protein, and somebody else is going to have a little more carb in there.
Hopefully down the road, to the continuous glucose monitor, they're going to be adding a continuous insulin monitor too. I bet that's the next tech that's going to come out.
All very fascinating.
It is kind of.
Thank you all for the discussion.
That's good questions. Okay. So I think we have done food. So step 2 is just assessing neurotransmitters using the chart. And, bring in the amino acids, bringing in the, other cofactors as needed to really feed the brain, specifically the supplemental nutrients that it needs to function ideally.
Christina, is this for the mental health disorders you're talking about?
This is kind of in general, when you've got somebody walking in your office with a lot going on and you want to run and hide because it feels way too overwhelming. This is a way of thinking through what you do first, second, third. And as I'm going through it now, I'm thinking, ooh, I want to add this and I want to add that and I want to add the other. I did this a couple years ago, so it needs updating. But it's still relatively accurate in terms of, you know, the stages you want to go through in your thinking. And yes, this is going to apply to major mental illness, as well as addictive disorders, as well as, you know, depression. Some things are easy. Some clients come in and it's just really easy. You know exactly what they need within 5 minutes of them talking to you, and they're off and running. Other people, not so much. Okay, anything here that wants to get talked about? Are we all good here? Okay. This is where it gets complicated. This is where we use both the NAQ, but you know, all of level 2 goes through these different steps, because this is where there can be a lot going on. And you need to sort of figure it out step by step by step. And to know what questions to ask from the get-go to help you figure out which of these pathways are you going to go down, right? Because each of these is a pathway. Pyroluria is a pathway. Hormones are a multi-level pathway. You know, genes are pathways. Detoxification is a pathway. And so it's like when you first look at a client, what do you need to know initially to determine which pathway you start with? And this is where some clinicians start out with, you know, an enormous number of either questionnaires, like Julia, or an enormous number of lab tests that the doctor wants done before, you know, she sees the client or patient for the very first time. And I like to do an actual interview in first session first for myself to determine, you know, what questionnaires I want to give the person, what, you know, tests I want to order, that sort of thing. So I do it a little more slowly than other clinicians do.
Christina,
Mhm.
what tests do you like to use for the methylation pathway? I know Great Plains has one, but I was just curious if you used a particular one.
I want to be looking at the whole pathway. So I want to, whatever gene test they've done, whether it be 23andMe, Ancestry, or one of the others, they all have the ability. You can then run the raw data through a software system that will pull out the entire methylation pathway.
Oh, okay. So you don't do, because I know like Great Plains has a methylation pathway test, and I wasn't sure if that was.
I don't think that's sufficient.
Okay.
Okay, because that's looking at pretty much just, if I'm remembering it correctly, your methionine to SAMe to SAH down to homocysteine. You know, but
so they're looking at metabolites rather than genetics, correct?
No, they're looking at genetics.
Oh, they are. Okay.
They're looking at the genes that regulate that pathway. They may also be looking at metabolites. I don't remember, but you know, I want to know if there are SNPs in that part of the pathway, but it's a whole lot more complicated than just that. Okay. Now you look at this nice little methylation map here.
Mm-hmm. Oh yeah.
Okay. There's some things. So all of that looks at the right-hand side of this map, but on the left-hand side of this map is neurotransmitter metabolism,
Right.
and how you turn the aminos into the neurotransmitters, and the role of BH4 and the role of toxicity and what gets in the way. And all of that matters too. And then you have COMT, you've got the genes that break down the neurotransmitters in the synapse.
Right.
And
Which genetic testing are you looking towards these days to analyze the raw data? There's so
Okay.
many out there now that I've tried to vet and done comparison searches, but just curious what you've
so
landed on.
far, I still like the one I'm using, which is through Tree of Life and Dr. Bob Miller, but it's very practitioner heavy and it's not end user friendly at all.
Right.
This is but it's very useful if you know what you're doing and you don't get easily overwhelmed by way too much data. It's extremely useful. I'm now getting extremely interested in this particular lab that I haven't spent much time with, but I will be spending time with it. I've looked at lots and lots of the other ones, and right now this one is floating to the top of the heap. And I'm going to spend time exploring it. You know, that of all of the several, I've probably looked at 4 or 5. I've looked at, this is the one that I've decided I want to pay attention to.
Okay, cool. Thank you.
Yeah. One of the reasons I want to pay attention to it is because the report, it gives you a series of reports for different health issues. It tells you what the genes and the SNPs are, but it categorizes it, including a whole report on all of the genetic SNPs that regulate mental health. So they have an entire mental health report.
Did you by any chance look at the DNA company or self-decode?
I've glanced at those and nothing jumped out at me. If they have a really good mental health report, then I would look at them. Do they?
I don't know specifically about the mental health report. I was just looking ones for the most inclusive, and I did see one gentleman. I mean, it even goes down to who you're using to get your raw data, because
Oh yeah, totally matters who you're using to get your raw data.
Because the ones that came out on top for getting the raw data was 23andMe and Ancestry, and self-decode was in there. And I was actually looking at self-decode because I thought that they were all inclusive as far as the what they did with that raw data, as far as giving you the information, although I don't know specifically about mental health per se as a category. But they fell in third place out of the other two as far as if you went with them to get the raw data. They missed several SNPs, even though they claim to be testing all like this super number of SNPs, but they're not necessarily relevant.
Right, and there's some concern, like the company I'm working with. There's some concerns that in 2017, 23andMe changed the SNPs they were looking for and left out what one company considers to be some really important SNPs. So it's a little bit of Wild West out there.
Yeah, and it's expensive to dabble in,
Everybody's going to say they're the best, but I think you need to know what it is you're looking for.
Right.
Right? So for instance, if we're talking about genetics, let me close this for a moment. And see if I have this up here. Doesn't look like, I don't think this is it, is it? No. Let me look for something for a moment. I will be right back with you all. Um, Oh, there it is, because you're open. This is one of the possible printouts you get from the company I work with. And they organize the data in terms of this pyramid and different categories of genes. And so it helps the clinician kind of organize the information. Now, green means that you've got really good, adequately working genetics. This is my report. Okay, red is bad. Orange is not good. Okay, so you've got like, what do you have here? You've got green, yellow, light orange, dark orange, and then red. Yeah, how many light oranges and dark oranges do I have floating around here? Okay, especially these bottom three are all of your detoxification pathways. My body does not detoxify very well. Okay, so this is one of the reasons why I have all of the chronic health issues I have. Because, you know, I've just got a lot of SNPs floating around in lots of areas that are impacting all sorts of things. So this is the report, and then you click on it and you get a whole lot of data that you have to know how to sort your way through. I think this is really useful because this can help you think through, you know, what is it that you want to be first looking at and second and third. You know, they're very clear that unless you address the problems down here, if you try to start with the problems like all the way on top, like with MTHFR or B12 or whatever, you're going to jump the gun and you might actually make the person sicker. That you actually need to be opening all the detoxification pathways down here first. And then you can deal with what's above. So it's just a kind of interesting way to think about it.
And that's from Tree of Life?
But yeah.
Okay. But if you had to do
I
it
think
over
they're
again-
calling themselves functional methyl-genomics. But you
And then
need to be a practitioner and know what you're doing.
right.
Some of the other tests, you know, are really designed to the end user and just give you the information you need to make changes in your diet, changes in your lifestyle, and you know, don't give you the background information. They just give you the conclusions. So Bob really doesn't give you many conclusions other than, you know, supplements from his company, but you get all the background information. So it depends what you need and what you want,
Right.
and your level of sophistication and ability to wade through data.
And did you give them the raw data, or did they collect the raw? Did
I
they
did,
collect
so
the samples themselves?
that was from I think this was from 2016 that I did 23andMe.
Okay.
And they keep updating their database so that the report, if I were to print out my whole entire report now, which is many, many, many pages, there would be a lot more information in it than there was in 2017 when I first did it.
With 23andMe.
No, because 23andMe just gives you the raw data.
Okay, so you're talking about with the Tree of Life, what they're doing with the information, right? Yeah, I think that's what Self Code, they keep growing what they're doing in
Yeah.
reports. So, okay. Okay, cool.
All right, so it's 12:30. Do we want to keep going? Are we done? Where are we
I
at?
actually need to head out.
Okay,
And me too, and I'm hungry.
all right, so we'll stop at this point.
Great
But,
call, though.
thank you
Thank you.
all. Lovely having you here. This will be posted both on YouTube and in the closed Facebook group.
Oh, boy.
So, thanks for all your questions and the discussion is wonderful. See
Thank you.
next time. All
Thanks,
right, bye,
Christina.
everyone.
Bye.
Hey.